Good morning. I wanted to welcome everyone here and online to HIV Grand Rounds. We have a fantastic series of lectures this fall, and we're very excited to kick it off today. I'm Elizabeth Imbert, and I'm an associate professor in our division, and I'll help coordinate Grand Rounds this year. A few housekeeping items. Grand Rounds will be here in Carr Auditorium every Wednesday, 8:30 to 9:30. The one exception will be September 17th, and I'll remind you of all of that next week. It will be in Pride Hall. Now I'll turn it over to Dr. Monica Gandhi to introduce our speaker today, Dr. Diane Havlir.
I also wanted to say welcome to the infectious disease fellows who are interviewing with us on Zoom. Thank you very much for joining us. It is really my honor to introduce Dr. Diane Havlir, who is the chief of the Division of HIV, Infectious Disease, and Global Medicine here at San Francisco General. Dr. Havlir came and trained here at San Francisco General in the early 80s. She was profoundly moved by the HIV epidemic and spent her entire life dedicated to this infection. She went for a residency and then came back and has essentially then was on faculty at UCSD and has had many accolades and many honors. She is the director of the AIDS Research Institute. She's on the WHO Treatment Guidelines Committee. She is the principal investigator of the large search study that has randomized communities in East Africa and really developed paradigms of care. She is profoundly inspirational to all of us. We have had a pretty difficult 2025, and I will say that she has showed profound leadership and guided us all through these times. It's really incredible honor to work with Dr. Havlir, and today she is going to talk about HIV in 2025, progress within reach.
Great. Okay, thank you so much, Monica. And I want to do also a special welcome for those of you online, the potential fellow applicants who are visiting. We have a wonderful environment here, wonderful institution, and we certainly hope that you will come here. The topic, well, I also would like to acknowledge, building on what Monica said, 2025 has been a very tough year. It's only been 9 months. Doesn't it seem like 9 years? I mean, every day brings something new. What I decided to do for Grand Rounds is I am not going to talk about all the challenges, all the modeling, all the doomsday scenarios. What I'm going to talk about in Grand Rounds today is what we can do as providers for persons living with HIV and persons who are at risk for HIV based on the new evidence that we have. For those of you who know me, I'm an eternal optimist. And, you know, with disruption comes opportunity, and we need to stay positive. And this is really what we need to do during these very difficult times. Okay, these are my disclosures. Over the last 10 years, I've received NIH funding, non-financial support, which I'm very grateful for HIV infectious disease research from ViiV, Abbott, and Gilead Sciences. The objectives today are to review the global state of HIV and highlight opportunities to make progress in prevention and treatment, to review our most recent data from San Francisco, state of HIV, and our local opportunities to make progress, and then finally to highlight some of the advances in our field that you will hear about in the coming year in Grand Rounds. So let's start globally. The title of the UN Global AIDS Update this year is AIDS, Crises, and the Power to Transform. This report, which is hundreds of pages, has great data within it. And let me summarize some of the high-level points. It shows that the responses to treating HIV and reducing new HIV infections continue to be very impressive, but also very uneven. Momentum and means that existed to reach the 2030 targets were disrupted by the funding crises in early 2025. We know that old models of external financing are coming to an end, and we need to change for sustainability. I have to say, I think the HIV community needs to be very proud of the capacity we've built. We need to recognize the tremendous financial investments that have occurred in our field. And it is not a failure, but a natural progression that these financial models need to evolve over time. And I would say, parking aside, that the way change has been done by our own government in a very precipitous way, which is unacceptable. Change is needed. And there are very smart, dedicated people working on how we can change and evolve for sustainable finance systems. So let's take a look at the data. So we have 40 million people who are living with HIV, people. And this, I just look at this number and I'm just so proud, 32 million people accessing ART. For those of us who have been this in the long run, I remember sitting in a room with people when we had this goal to put 3 million people, it was called 3 by 5 on 2005, and everybody said it couldn't be done. And look at this number now, over 30 million people. And I can't tell you how persuasive the naysayers were during this time. We still, nevertheless, have over 1 million new HIV infections and over 600,000 deaths due to AIDS. Every single one of these deaths, in my opinion, is preventable. HIV continues to be the pandemic of our time. 90 million people over the course have been infected with HIV, and we've had more than 40 million deaths. So this is like an easy question we're going to start with, not meant to be a trick question, just to see if the Q&A is working. So in 2024, what percentage of people living with HIV are women or girls? Is it a little under half? Is it a little over half? Or is it about 3/4? This is where I never know if I should do the Jeopardy song. Do. Okay, let's see where we are. Okay, so most of you said, half of you said 63%. The answer actually is 53% of persons living with HIV are women or girls. What we do know, of course, is that there are populations globally that are disproportionately living with HIV. And those include gay men and men who have sex with men, over 7%, sex workers, nearly 3%, 7% of people who inject drugs, 8% of people who are transgender, and 1.4% of people among prisons. This is highly heterogeneous, as you know, around the globe, but this is a large number of individuals. So one of our goals of therapy, as we know, is to achieve a viral suppression. The amazing data we have to support that treatment is a 2-for-1. It keeps people healthy and stable who are living with HIV, and it prevents onward transmission to other people and also from mother to child. So this, of course, is a major focus in the care of persons living with HIV. So once again, get your phones ready and let's see what people think where we're at. We can see we've got 63% on the low end, and we've got 93% on the higher end. Okay, so nobody said 93%. It's true, it's not 93%. And most people are somewhere, over half the people said 73%, which is the answer. So 73% of persons living with HIV have viral suppression. Now, one thing about when we look at these data, we need to realize, think of all the things happening on our planet right now with wars and people being displaced and things for people's lives that are a lot high priority than collecting data. These data are all estimates. Some countries haven't given data to the UN for 3 years, but this is the best we can do. So that's what we have. So let's look at it. So what this shows in the report this year, this graphic, the way they chose to present it was to say, okay, how many people are aware of their status? And we estimate somewhere around 87%. Now, one of the campaigns that we started, which was extremely successful, was this 90-90-90. And the first metric in 90-90-90 was 90% of people to know their status. Now we bumped it up to 95%. But this is pretty close. We're not exactly sure if this is completely accurate. There's motivation for people not to disclose they know their status, but at least globally, that's a big progress. But if we then use as a denominator all people living with HIV, here we start seeing some drop-offs. Here we see that 77% are receiving antiretroviral therapy, and then a small drop-off of people having viral suppression. This is also really amazing. I mean, and what this reflects is we have these unbelievable single combination pills with powerful drugs, integrase inhibitors that are bolstered by partner drugs that for people who are offered ART in very supportive environments can achieve viral suppression. So in the HIV field, where we're at is never good enough for us. So what we do is we analyze where our gaps are. And this is a gap we can hone in on and to say, where is the most unmet need for people who are not yet receiving antiretroviral therapy? And it's in two regions, Eastern and Southern Africa, the orange on this graphic, and then the in Asia and the Pacific shown in the hot pink. But just for everyone to know, every single region is on this graphic because we have not achieved access for all people living with HIV. So let's drill down a little bit more. This is another graphic that they included in the report this year. And let me start just looking at women and men. We've known for a long time in HIV, particularly when we look globally, and this, of course, is disproportionately these data affected by people living in sub-Saharan Africa, that the uptake of ART and access to ART has been higher in women than in men. And our group has studied this. There's a lot of reasons. People in this room, we have personal insights in this working in the healthcare system. Women have reason to seek healthcare system, when they're having children in the childbearing years. The healthcare systems, in many ways, one could argue, have been designed a little bit more friendly for women than I would say for some men. Men just have different health-seeking behaviors. But okay, so if we look globally, men are still behind, but we have spent a lot of effort, and I think successfully, making this gap smaller and figuring out what is low barrier healthcare. How do we deliver it for women? How do we deliver it for men? We don't, just with basic principles. And I think we actually have made some really significant progress there, but of course, not good enough and need to keep going. But when we start to crack that nut, we are going to see benefits not only for HIV, but for other chronic diseases. Okay, so I think the big point from this slide, the very distressing point, and every year when I give this talk, there's some element of children being left behind that gives us all a pit in the stomach of, again, here we can see where we're at with achieving viral suppression for children. And it just doesn't look good, and it's completely unacceptable. Now, we've talked about previously, what are the reasons for that? A couple of reasons are that just in drug development per se, I don't know if we have any pediatricians in the field, pediatricians have smaller number of patients, smaller patients, and the drug companies and investments for studies for kids are just less. So they often have to wait until we do studies in adults, and then we do them in kids. Secondly, the formulations are different, and the formulations can be more complicated. The good news in HIV has been tremendous progress. The formulations for kids used to be unbelievably complicated and honestly torturous for the kids. They'd have to drink this ritonavir solution that tasted terrible. They have to take like 15 pills and they have to do all these things. And the problem is, as we know, compared to taking one pill once a day, which the adults were doing, right? If you take part of your meds, and this was very hard for the kids, they're throwing up, they don't want to take their meds, you get drug resistance. So one of the reasons, of course, for viral suppression being lower in kids is not only the delay in the formulations and the access, is their ability to take complicated regimens during this time. So I think there's a lot of people, I don't know if Ted Worrell is a pediatrician really leading global efforts with this. We're trying to make progress in this area. I pulled out the stat, which I put on this slide, which was 14 to 20% of children less than 1 year who had treatment interruptions subsequently died. And that is, if that doesn't move you, you're in the wrong field. And it just reflects where we need to put more effort. Okay, so that's access to ART and viral suppression. What about new HIV infections? Yes, they're declining globally, but we certainly are not on our trajectory for our 2030 targets, which is shown in this graph. So once again, let's analyze this a little bit more. What were we told in the global report? Where are the new 1.3 million infections occurring? Same places with the viral suppression. And of course, these are related on many levels. The largest proportion are in Eastern and Southern Africa and in Asia and Pacific. But of course, occurring in all regions. So let's take a look at this graph that's on the right side. So we have made tremendous progress in many regions of the world in reducing new HIV infections. And this is honestly primarily as a result of treatment as prevention. When we treat people, benefit their health, we get this secondary gain of reducing HIV transmission. But look at these reductions across Eastern and Southern Africa, and now across Western Africa. But we are not seeing those reductions globally. And even though one always has to be careful with graphics, the absolute numbers in the regions where we're seeing the increases are smaller, okay, because few infections. We can't ignore these increases that we are seeing. So this just completely jumps out, Middle East and North Africa. So pulling out my cheat sheet to tell you what countries, because I couldn't remember them, are in the Middle East and South Africa, North Africa, where we're seeing this: Egypt, Jordan, Tunisia, and Morocco. And I think this is probably a complete underestimate of what is happening there because of the quality of the data, not because of public health officials don't want to submit them, but because of the resources they have, the legal laws, the motivation for people to hide their status, and because groups that are disproportionately affected by HIV in these regions are often under attack and in some cases can be jailed. So the two other things about this region were notable to me in the report. One, that 20% of these new infections are in 15 to 24-year-olds. So it is a youthful a number of new infections. And then secondly, although the proportion globally of HIV of people infected is smaller in these regions, it receives, get this, less than 1% of all the funding for HIV. So this is a very, very bad combination. We've got the wars, we've got the displacement of people, we have the political climate, we have no money, we have the inability to collect data. And that is why we are seeing what we're seeing. And that is what happens. And I promised I was not going to talk about doomsday scenario. What happens when you don't put the systems in place that everybody in this room on a daily basis really fights to do, and we have done for the last 40 years. So let's go back to speaking of young people. I thought this was an interesting graphic, and I don't think it's going to be new news to those of you in the HIV world, but if we look now at not people living with HIV, but new infections in young persons, this is stratified by gender, and orange is female. I don't know what color that is. I'm just going to call it blue. Blue is male. And 50% of new infections in young people are in women, 43% in men. But what you can see, this dramatically shows the heterogeneity. In Eastern and Southern Africa, it's 77% and 23%. But if we look in the Asia and Pacific, it's exactly the opposite. Okay, it is more males and females. One of the things that's happened in the HIV field, when we get to dramatic about this, and we need to realize around the world, this is whether you're in San Francisco, whether you're in Thailand, or whether you are in Uganda, both men and women, males and females, are having new HIV infections, and we need to make sure we are reaching all of these populations. Okay, back to the children. It's mother-child transmission is completely preventable, and it should be our goal. We've done it in San Francisco, but globally, we could do better. So on the left graph shows the trends in time between 2010 and 2024. Orange is East Africa. You can see declines. This is good, and particularly, I think, in East Africa. What I'd like to draw your attention to is which phase and where's the lesion, if you will, of why we're still seeing these infections, and compare what we're seeing in Eastern and Southern Africa and what we're seeing in Western and Central Africa. Okay, so let's start with the blue is mother was on antiretroviral therapy but didn't have a suppressed viral load. Super important, very addressable, but a pretty small proportion in both these regions. Let's take a look at the green box, okay? Mother did not continue antiretroviral therapy during pregnancy or breastfeeding. This was a much bigger issue in Eastern and Southern Africa than in Western and Central Africa. Once again, anybody who's had a baby or in a family with a young child can understand why this happens, particularly when we had very complicated regimens, and it's something we need to get better at with the services. Now, the yellow box is really completely unacceptable. Mother did not receive antiretroviral therapy during pregnancy or breastfeeding. And you can see, look, in Western and Central Africa, there's a huge number of people. So Western and Central Africa, it's because the prevalence is lower, in some respects, it's harder in health systems. And the reason it's harder in health systems, instead of having big clinics of persons living with HIV, you have a few people in clinics all around. So it often cannot be the priority for the clinic. So I think it's easy to criticize and say, oh, wow, why is this happening? But if you really think about it and you think about how health systems work and how they prioritize, I think it reflects the challenge that is faced in Western and Central Africa that has a lower prevalence. Then look at this, mother-acquired HIV, the orange box here, during pregnancy or breastfeeding. Wow, okay, that is also completely preventable. And we have new tools for that. And this box, it's up to us globally. We should be able to reduce, frankly, all these boxes, but that is one we have new tools for. Okay, so seems like in healthcare, we come back to money many times. So I have one question about money in the grand rounds today. And this is a question. How many low and middle income countries are increasing their spending for HIV in 2026? None. I mean, it's like, are you crazy? Like with the crises that we're in globally, financially, how would they possibly be doing that? 5, 15, or 25? Okay. I think before I read this report, I think I would have said maybe 5. I might have said none. So I think I would have said what most of you said. 25. Okay, this is a piece of good news. And this is, remember, journalism reports bad news. That's like the basis of what they do. We have to remember there is some good news here. And that is all the investments that we have made in training the leadership, the ministers of health. Many of them are people that work in HIV. They have really stepped up and worked to increase funding for prevention and treatment for HIV. And arguably, ART is one of the greatest advances in public health, in our lifetime, right? So, so what this shows is 25 of the 60 countries reporting to the monitoring program increase their domestic budget for 20, then 26. Now, okay, you can say, well, and I did not have time to dig into, did they increase it by $5? Is this a little bit of like they're playing a game? But I don't think so. I think that countries want to own their health. Some countries are capable of owning their health, including HIV. They've overcome a lot of the stigma, not all countries, and they're capable of doing it, and they want to do it. So this was my take, you remember, on the Eternal Optimist, on this report. Very, very happy to see this. So the current UN AIDS Executive Director, who has had a very difficult job in light of the past couple of years, this is one of the quotes that she had in the report. The AIDS response may be in crises, but we have the power to transform. And I'd like to channel that and really propose to you globally what I think I have 4 or 5 things that we can do over the next 5 years that could make a huge difference. Okay, so number 1, offer new injectable HIV prevention options. These injectables for prevention have been one of the most exciting developments in HIV over the last, even Diane's phone rings during her talk. You can just send that. Okay. Over the last 5 years. Okay, so we know cabotegravir works for HIV prevention. It's being rolled out in some countries. IM injections every 2 months. There's pain in injection site, but it improves over time. You can do rapid HIV testing. We don't need to do HIV RNA. It's highly efficacious in the phase 3 trials, US, Latin America, and Africa. So effective, these trials were stopped early. And resistance can occur. Dr. Kate Koss is really leading global efforts to really understand this more, but it's still, fortunately, extremely rare. Our research study that our research group that Monica mentioned, many of the faculty who work on that are sitting in the room and probably online. Just want to say, I think this was, we know that cabotegravir worked, but we recently did a very real world study in rural Africa where 80% of the people don't have electricity. The setting is very minimal health infrastructure, but also a place that's been very hard hit by HIV. And we asked the question, what if we offered prevention options, low barrier, not paying people to go to clinic, not signing 25-page consents, but just having the option to take oral PrEP, to take PEP, or to have CAB-LA. Would they have more time? These are people who are self-declared at risk for HIV, men and women. Where they recover for HIV, not to get HIV, compared to just the standard of care. And it seems kind of like an obvious thing of what we would find. The answer is yes, absolutely. Blue bars are the percentage of people who are at risk for HIV that are covered when they receive this, what we call the dynamic choice model for prevention versus the standard of care. And this choice model, where not only do you choose, but you change over time. Life changes. Sometimes you do PEP, sometimes you might want to do injections. Sometimes you can't do injections because you're traveling. I think previously it was very static, like pick your prevention, what's right for you. And the doctors would tell the patients, this is not a good model. We know that people know themselves best, they know their risk, and we can now offer them a couple of different options, which is great. I think most important, this study was not powered to look at HIV incidence, but what we found was profound. We saw absolutely no infections. And this study had like nearly 1,000 people. We called it a pilot, but it was a pretty big study. There were no infections among the people in the CAB-LA arm, and 7, very unfortunately, with a 1.8% incidence in the standard of care arm. And that is an underestimate because so unfortunately, there was one infant born in our standard of care arm who was not on prevention, who got infected. So I think this just shows that we can do injectables in a dynamic choice prevention model in resource limited settings. Well, deemed as the breakthrough of the year by Science magazine was lenacapavir, which is now approved in our country, based on 2 phenomenal studies, Purpose 1 and 2, both published in New England Journal. Once again, both stopped early because of the profound effect that lenacapavir in a sub-Q preparation every 6 months had on HIV prevention. In one of the studies, there were no infections. The other study, I think there were 2 or 3, and there was some resistance, but these results are truly, truly amazing and so exciting, and we need to put them into action. And the WHO has not dragged its feet. We have gone forward, and we have now recommended lenacapavir for HIV prevention with what I would call low barrier testing strategies. So this is good. Now what we need to do is, seemingly in an impossible environment, to tell you this is every couple of years this happens in HIV. It seems seemingly impossible. We need to overcome this and get people access to these long-acting preparations. And really thank you to everybody who's been involved in these studies, for people who are working to make global access. It's going to make a big difference. I just say one of my favorite studies at CROI this year, which is our annual meeting, was a study that was presented from Gilead about another preparation for lenacapavir that, instead of being sub-Q, which essentially people get depot drug deposits under their skin, is IM. And instead of being required to do every 6 months, which is in itself is amazing, only requires every 12 months. And the pharmacokinetic data was presented that it should work. This is like so exciting, and clinical trials are ongoing. So stay tuned. This also could be very, very transformative in our quest to really eliminate all new infections globally. Okay, so we're back to the UNAIDS director said we have the power to transform. I'm going to share with you something else that we can do, which we are doing, which is all the investments. And once again, I'm talking about globally, leverage these care systems for other diseases. In many low-income countries, there has been no concept of chronic care. The healthcare system is set up to deal with urgent issues. You get a knife slice, you have malaria, some acute illness, you get TB, nothing about chronic care. Well, as we know, fortunately, HIV is a chronic disease. It requires lifetime. So we, because of all these investments, have set up the infrastructure. We've trained all these people, and there's wonderful leadership in countries about now chronic care. So let's leverage this for other diseases. This is a picture of our search team, and I'm going to talk specifically about hypertension. From the very beginning in search, we said it is not a good idea to put HIV in a silo when we're thinking about countries where the prevalence is 10, 20, 25%. Because putting up a big sign, get HIV tested here, thank you to the US government and USAID for providing it, and you walk up to that, creates stigma. So we worked with communities, and what they said to us and what we said, let's do a multi-disease approach. Like, why are we calling out HIV? We're contributing to the stigma. So, we from the get-go were including hypertension in what we did, and won a very nice study that really was led by Starlee Shade and Vivek Jain from our division, was to say, if you just look at the costs of adding hypertension care, the drugs are very cheap, they're very generic. It's very small, it's very incremental. And for those of providers, hypertension care is is pretty straightforward. So I think this kind of started the momentum and really to make the argument that we should be integrating it. So now what are we doing? On a population level in search in rural East Africa and Kenya, we are building out already Ministry of Health funded systems, in this case, community health workers who routinely go to every single house and do tracking by training them to do blood pressure measurements, having digital devices that are compatible with the ministries of health to take the blood pressure, track people who have blood pressure. And we have a special separate program, randomized trial led by Matt Hickey, which shows a telehealth for people with severe hypertension, just to try to leverage what we have, bring it out from the clinic to the community. We're also doing HIV, of course, but we can use this for hypertension. And this thus far has been really, really successful. And we've seen in the first year over populations of over 40,000 people, population level reductions in blood pressure, and we'll have results of the randomized trial in early 2026. Now, one thing about policymakers is they like to see models to say how much, what's going to be the reduction if this is scaled widely. Matt Hickey has led some really nice work with Andrew Phillips, who's a modeler from the University College in London, to ask a couple of questions I wanted to share with you. And the first one is, what's the effectiveness and cost effectiveness of implementing hypertension care in primary clinics? And what do you get when you add community health worker screening? So the current state where we work is hypertension care is in hospital-based specialty clinics, low diagnosis, treatment, and retention. So the intervention is, let's just take our HIV clinics and include hypertension care, or on top of that, add community screening by health workers. I'm just going to share with you kind of the bottom line results of this, which is, and this was just recently published in PLOS Medicine, that population level screening by existing community health workers would substantially improve hypertension, diagnosed, treatment, and control. And this would lead to population reductions in MI, CVA, and CVD mortality. And I think this is very concrete modeling data based on real data that shows what we can do by leveraging this unbelievable investment that we've made in HIV. And to me, one of the legacies of the global response to HIV will be what we did for chronic disease in low and middle income countries. So summary of the global part of my talk is certainly HIV is far from over. We need to support lifelong ART for 40 million persons until we find a cure. Now we have to call out Steve. Oh, he's in the corner of the very back row. Steve, need to get on it. Okay, 1 in 4 persons are still not accessing ART. Children are being left behind, and aging populations require multi-disease care. There's still over 1 million new infections HIV every year. Global epidemiology shows profound heterogeneity in persons and needs, and progress can be made now. We have built the capacity for HIV treatment across the lifespan, for injectables, Cab-LA and lenacapavir for prevention, and to improve overall health. And for those of you who are just starting in infectious disease and considering a career, every single day in HIV is like a new day because we're seeing the evolution of this disease. And you could be the one is the first person to observe something new that we have not seen before. Okay, let's bring it back local. Okay, let's talk about the status of HIV in San Francisco, and I'm going to share with you some preliminary data from the surveillance report from our San Francisco Department of Public Health. I want to do a big shout out to people who work in the public health department in San Francisco who pull these data together. Thank you so much. We appreciate what you do. And one thing about San Francisco, we have a wonderful relationship and collaboration with the health department, and that is why we've been able to do many things that we've been able to do in San Francisco. Okay, back to the questions, guys. Okay, let's see some answer for this one. Compared to 2023, new HIV diagnosis in San Francisco, has it increased? Has it decreased? Has it stayed the same? Or we don't know because monitoring has been discontinued due to funding cuts. I think all these answers are pretty reasonable, to be honest. So let's see what you guys all think. Oh, nobody said that monitoring has been discontinued. Very interesting. So pretty split. The majority said decreased. Okay, so what's the answer to this question? Tiny. I'm not even sure if it's really significant. Tiny increase, or really about the same. 145 versus 139. Remember, this is not new infections. This is new HIV diagnosis. So even in San Francisco, when we have all these tools, 145 new HIV diagnoses in 2024. But compared to the US, this graph you can see, the red line, has been a remarkable effort by the collaboration of scientists, clinicians, policymakers, industry, and very importantly, community organizations. So we're still on the 5-year downhill trajectory. We estimate about 15,000 persons living with HIV in San Francisco County. Okay, these are some graphs. So let's take a look at who we are diagnosing, newly diagnosing for HIV. And this goes across a 4-year period, 2024, to look at the trends. So about two years ago, we saw this spike in the Latino population. That's the green bar on the top, which is still the highest number of new cases. And we really tried to swing in action with this. So it's up a little bit, but I think this is good that now, okay, it's up a little bit from last year, but it's down from 76. That is very good. Okay, 76 to 47. However, just remember, there are things happening that are driving people underground. That's not really the word, but not wanting to access diagnosis because of what's happening in our health systems. So we have 47. Is it really 47? I'm not exactly sure. And just something before we do a big celebration of how great this is, we really think about. Okay, let's break it down by gender. And here you can see pretty consistent declines in MSM who inject drugs, just, across. Here's trans women, which we saw this spike in 2021. Once again, everyone is preventable, a little bit of downward trend. This is not a downward trend. What do we see here? This is women. Okay, so let's take a little bit closer look here. Overall, you see in women, and then let's look at that gray line, the 21. That's heterosexual women. Okay, let's look even more, drill down a little bit more. Okay, let's look at ethnicity and age. Black, African American, 46%, last year 31%. And let's look at age, 50. 35%. Now we have experts on our faculty, including Elise Riley and others who are really studying this, but this is what's happening in our city for a variety of reasons, many structural, social, economic reasons. Also, a little bit more data, 73% US born, but 12% non-US born. Look at the homeless, 42%. Need to be optimistic. Our new mayor and public health director has made a commitment to address this, but I would say, I don't want to be too melodramatic, but this is shocking, jarring. Okay, this particular statistic, and also late diagnoses. Okay, so what can we do? I'm going to talk through 5 things. This is for all of us collectively in San Francisco to think about doing in order to make things better in our city. Okay, so first, it's to enhance HIV prevention with these new products. So we've talked a little bit about getting to zero. San Francisco, for those of you who are visiting, Getting to Zero is a freestanding organization that operates under collective impact that Susan Bonder and I and community groups started over 10 years ago that brings the city all together and talks about what are the main issues and what is our advice on strategies of how we should act. So Al Liu has really taken a lead in the prevention. Brad here also is one of the big leaders for HIV from Kaiser, very actively involved. So, San Francisco has always been on the lead edge. Susan Buckbinder is one of the world experts in HIV prevention research of developing and adopting biomedical prevention. So we've got, the injectables and long-acting products and many in the pipeline, which we're actively studying. So we've got a lot of initiatives right now in our city and working with the makers of these products to really scale up these products, and particularly in low barrier access sites. One of them in the building right next door to us, the lobby, where we're really trying to do all these, roll out all these programs. Okay, so if anyone's paying attention, this should not be number 3, it should be number 2. I just noticed this morning when I was going through my slides, but okay, number 2. First of all, do you like the picture of like, oh, the band, very exciting? It is, this is very exciting. Once again, if this doesn't excite you, probably this field is not for you, okay? So we need to optimize the use of injectable products for treatment, not just prevention. This is a major breakthrough in HIV therapy. So we're in a new era, okay? And it's not just injectables. There's products in the pipeline that are going to be oral, which is going to be fantastic, okay? This is going to drive progress over the next decade if we stay on top of this and get our programs in the community. So injectable is a great option for many people, and I really don't want to diminish for people who have viral suppression, the improvement in quality of life they can have when they move from pills to injectables. One of the things that we've seen, I would say as a provider, will have people on like 10 medicines for chronic diseases and their HIV medicines. And just moving their HIV medicine to injectable, even though they still have to take pills. Okay, it's not like no pills. Very happy, makes it very happy and improves their quality of life. So we just really need to remember that and keep offering it. The important point, and really pioneered and led by our program, really under many people I'll talk about next, injectable can be life-saving for persons who have not achieved viral suppression due to inability to take oral medications. And of course, now we're combining. So this is just an OFID, just to say, if you model what happens if we offer HIV long-acting injectables to people who don't have viral suppression, the original studies that led to the approval of these drugs was only for people who already had viral suppression. If we extend it, we're going to see a lot of benefit. So 2 studies I'd like to highlight here. And you will hear a lot about this on Grand Rounds coming along, and Monica Gandhi really has spearheaded this. One of them was in CID. This is 59 persons with viremia starting Cabriv at what happened at 48 weeks. The baseline viral load was about 42,000. 80% had viral suppression at 48 weeks. And this is a population that has a lot of other things going on in their life. Okay, they might have issues with substance abuse. They might have housing instability. This is not easy. It's really amazing the results that have been seen. I have a pictures of a couple of leaders of these programs and researchers who are studying it. Yes, we see drug resistance. Do we expect that? Yes. But when the other option is death, because there's no therapy, this is a price we have to pay. And we are going to be having new drugs. This was another short report that was published in JAMA by Matt Spinelli and Monica Gandhi. Just want to shout out to Janet Gorkowski, who has really been a leader in the SPLASH program in our clinic, which is how this is all happening, which looked at 370 persons, some viremic, some suppressed, of the really rapid rates of achieving viral suppression that we have achieved. And these investigators, these data have led to changes in the US guidelines. And that's why we do what we do. And we not only want to change guidelines, we want to do it and get it available for people. Okay, so about 10 years ago, we started something called RAPID, which is treatment upon diagnosis. Now, for those of you who come in new, this seems like a bizarre concept. Like, why is this such a big deal? Okay, one has to realize when HIV first came out, people were like, oh, with ART, oh my gosh, it's a lifelong commitment. If you have to go through education and training, you have to promise me you're going to take your meds every day so you don't get resistance. And before I even consider starting with you, you have to make a commitment to do this. So people often did not even start ART for weeks to months. Okay. Now, do we do that when someone has an MI? Do we say, oh my gosh, you have heart disease, we're going to be giving you? No, we don't do that. And this was our big argument. And also, of course, for transmission. So we started a RAPID program, which was treatment upon diagnosis with all the wraparound services. It honestly has been adapted all around the world. I've given talks of people who have used it, which is what we want. And we've shown that it makes a difference. So now we're talking about rapid restart. What is rapid restart? This is for people who have fallen out of care who come back. Everybody in this room who takes care of patients has patients like this for reasons probably mostly because of our health system that's completely fragmented. People change care, they fall out of care, they come back. So, and studies led by Jorge Salazar, Cesar Coffey, and Kat Christopoulos, they analyze like what's happening in our clinic. And this includes people who have fallen out of care in general for like 6 months, okay? And here this shows how many rapid restarts that we did. And we had a program that we started. We took our rapid program and we adapted it. Well, I don't think anyone who takes care of patients in the contemporary would be surprised at these data. The outcomes are lagging and there are gaps to fill. So what you can see is that the viral suppression rates, we just skipped to that, only got 5 minutes left, pretty low, 57%. And as Susan Coffey would say, it's easy to start, it's the continuing, and it's what you need to do for people who might have more complicated decisions that you need to make when you start after they've had prior therapy and the kind of wraparound services they need. So right now, we're building out a program. It's different from MORD 86 lessons learned in RAPID, but it's got some of these distinguishing features and we will be studying it. And I want to do a big shout out to people who work on the RAPID program and the Rapid Restart program. Keep going. We're going to crack this nut. We are going to make this better. And then we're going to share what we've learned for people locally and around the world. Okay, so we need to lead and act on STI prevention. Annie Lukemeyer had the landmark paper published in New England Journal showing that doxypep works to reduce syphilis, chlamydia, and gonorrhea. San Francisco adapted the policy before the CDC. They disseminated it via Getting to Zero. And what we have shown is a reduction in citywide rates of both chlamydia and syphilis. And this policy was a really big, gutsy move by our health director, Stephanie Cohen. And I just want to do a shout out to her for this. Okay, so since we're short of time, I'm just going to flip through slides and just describe the points that I wanted to make. So what we see is we see a reduction in chlamydia and syphilis, but we don't see a reduction in gonorrhea. Okay, and this has also been seen in Kaiser. This is like amazing. If you just look at that graph on the left, look at the chlamydia cases there and there. This is before and after doxypep. I mean, it's incredible, right? But not in gonorrhea. Okay, and Hyman Scott did a beautiful analysis in the Strutt Clinic, about 2,000 patients, half that did doxypep and half who didn't, and we see reduction in STI incidence. Yes, there is resistance with tetracycline. It has increased. This is something we're studying and we need to figure out, and we do need new drugs for gonorrhea. This is one of my favorite studies also from Corey. I just have to tell you what these investigators did from Italy. I always love studies from Italy, I'm not sure why. But they said, okay, so we use doxypep. Are we really using less antibiotics? This is the argument of people who say we're gonna create a resistance nightmare globally, okay? And it took me a while to figure out what DOT was. It's days on treatment. So basically what they said is when you use doxypep, you end up using less antibiotics of days on treatment because you have less infections. I just love this. They published it recently. It was a really important paper. Okay, we have lots of STIs still in San Francisco. Some of these numbers are shocking. It's disproportionately affecting Black African Americans. Look at that 1,535 of chlamydia for Black African Americans under 25. Fifth thing, accelerate hepatitis C cure and elimination. In this auditorium, when these new drugs came out for hepatitis C, I said to Annie Lukemeyer, we need to cure every single person in Ward 86 with hepatitis C. She tried, she really made a great effort. We're almost there, but then they started Hep C, and shout out to Melissa Sanchez, Annie, Stephanie Cohen, and others who have really done a great job in getting a test and treat model for hepatitis C in our city. And I'm going to jump to that and just share with you, we've got the new point of care testing for hepatitis C. So what we're doing is we're taking the playbook for HIV. We should be doing this. We can do rapid testing for hepatitis C. We can start drugs the same day. We need not very much monitoring, and we should be able to eliminate hepatitis C. Like, we need to do it in San Francisco. We know what our gaps are. And this is another example of what we can do people consider coming to what you can help us do if you come here for training. Okay, so we've got the tools to transform. Here's all the things we're going to be doing in grand rounds and learning about so we can improve our practice over the next year. This was a paper worth reading by Chris Fire about on going backwards, but I was a little bit, I don't know, taken aback by all the backwards talk in here. But I like the sentence he wrote: we will resist going backward to those early years with all we have. And I would say we need to change the narrative from what we can't do to what we can do. What is being taken away to what we have. How we don't need research to how research is more important than ever, and from why we have failed to why we have succeeded. And I want you to look at this graph, okay? I pulled this out. This is hemoglobin A1C, people 20 to 44 years. Think about the analogy of viral suppression and where we have come in the HIV field. Like, we're criticizing ourselves. 74% is not enough. Well, 37% is clearly not enough. And I always tell people, never underestimate the HIV field of what we are going to do and what we can do. This is a picture of the Gay Men's Chorus who were at Croy this year. They just gave the most beautiful presentation and told us, really thanked us for all the things that we do and how they're behind us in this difficult time. And with that, I'm going to end my talk and thank you very much for your attention. Look forward to seeing you for the rest of the night.